Welcome everybody and happy start to 2021. A few housekeeping notes is for any questions, please put them in the chat and we will get to them at the Q&A session at the end. I'm honored to introduce to you today a wonderful mentor of mine. She is someone I desired to work with long before coming to UCSF, as her well-deserved reputation extends far and wide. Personally, knowing her generosity and compassion, I can think of no better person to start off 2021. Dr. Diane Ehrensaft is a developmental and clinical psychologist, associate professor of pediatrics here at UCSF. She is the director of mental health of the Child and Adolescent Gender Center down at UCSF Benioff Children's Hospital. She is also the co-editor with Dr. Colt Keogh-Meyer of the Gender Affirmation Model and authored 2 books, The Gender Creative Child and Gender Born, Gender Made. She specializes in research, clinical work, training, consultation related to gender expansive children, and publishes and lectures both internationally and nationally on this topic. Dr. Ehrensaft is presently co-investigator in a 4-site NIH grant study studying the effects of puberty blockers and gender affirmation hormones in gender expansive and transgender youth. She is also the principal investigator in a companion 4-site grant, the Gender Journey Project. This is studying the psychological experiences of prepubertal gender expansive children. She has served on the faculty here at UCSF, as well as UC Berkeley, the Wright Institute, Psychoanalytical Institute of Northern California, and the World Professional Association of Transgender Health Global Education Initiative. She is the founding member and senior clinician of A Home Within, a national organization addressing the emotional needs of children in foster care. So without further ado, I welcome Dr. Diane Ehrensaft.
And thank you, everyone. And I'm delighted to be here and to be able to launch 2021. May it be better than 2020. We are all hoping. And what I tried to do today is in less than 50 minutes, consolidate what we've been learning in terms of mental health care for gender expansive and transgender children and youth. And I'm going to put in a plug at the beginning of my presentation, which I'm going to put up the slides in a minute, that if any of you are interested in pursuing this further, the Child and Adolescent Gender Center has a mental health wing. We call it Mind the Gap. We have meetings once a month, the first Sunday of the month, in which we discuss, train, and consult among ourselves so that we can fortify our work with the kids. And we invite people to join us. And if anybody's interested, they can contact me and let me know. So with that said, I'm going to put out my slides and I will go from there. So this is what we're talking about today, which is gender in all its splendor. And I will say I have no disclosures to report. And here are the course objectives for this grand rounds. We delineate the major components of the affirmative model of gender care. To identify the specific parameters and needs of transgender versus non-binary versus gender expansive children and adolescents. And to be aware of the clinical challenges in interdisciplinary care of transgender, gender expansive children and adolescents from a mental health perspective. Now, this is a new working model that a number of us has put together, which is, we'll just call it the new developmental theory of gender, which may be very different from what you learned in school, certainly different from what I learned in school in the 1960s. So number one is the child uses their psyche to weave together a unique 3-dimensional, what I have called a gender web, with major threads from nature, nurture, and culture. And every child's gender web is unique like a snowflake, No two children are alike. Another way of looking at this is something I borrowed from my work studying D.W. Winnicott, who wrote about the true self, the false self, and individual creativity. I lifted those concepts and applied them to gender and realized that our gender can be understood to be organized around each of us having a true gender self, which is the core of us, a false gender self, which is our covering that we present to the world, uh, either to conform to expectations or to protect ourselves from harm, and our gender creativity, which is how we go back and spin together our unique three-dimensional gender web. And when we think about the development of gender, we have to think about different entities. There's our sex, typically designated to us at birth. There's our gender identity. There's our gender expressions. And then there's also our sexual identities. And these are separate but intertwining entities. So if we think of it this way, gender identity is the being of gender, who I am. And gender expressions is how we do our gender. So it's the doing of gender. And here's where the environment comes in. If the environment impinges on the child's spinning of their gender web by grabbing the threads from the child, then that child's true gender self is going to be at risk of being suppressed or even annihilated. But if the parents are able to keep their hands at their sides and instead appropriately mirror back to the child's unique gender self, then the true gender self will more easily unfold, albeit under the influences of the larger surrounding environment. And that message to parents is the same message to us as mental health providers, that if we can mirror back to the child the gender the child is bringing to us, we can help fortify that child's true gender self. Now, that's the developmental sense of gender, but let's just spread it wider, just 21st century concept of gender, not just development. So number one, there are infinite possibilities rather than just two, male, female, for the true gender self. Number two, neither constitution nor environment prevails. Both live in dialectical tension with each other. Number three, the true gender self encompasses both core gender identity and chosen gender expressions. Number four, neuroscience interfaces with genetics. Genetics interface with intrauterine environment. Physiology and the organism interface with environmental provisions. Sociocultural political landscape both wraps around and is pushed in new directions by all the aforementioned forces. Now, this is a little blurry on your screen, but we put together about a decade ago, we started doing this as an international collective group, the Gender Affirmative Model of Care. And these are its basic premises. Number one, gender variations are not disorders. They are expectable and healthy variations on humanity. Number two, gender presentations are diverse and they're varied across cultures. And therefore, this requires cultural sensitivity, that we all have to be anthropologists as we understand gender as it walks into our consultation room and the intersection of all different forces in a person's life. Gender involves an interweaving over time of biology, development, and socialization, and culture and context. And I would say here in number three is embedded the concept that your gender isn't fixed at age 6. Your gender is evolving over your entire lifetime. Number four, gender may be fluid. It's not always in boxes. Number five, if present at all, you should observe individual psychological or psychiatric problems in someone who is gender expansive or transgender, these are more often than not secondary to negative interpersonal and cultural reactions to the child or to an adult. Therefore, number 6, gender pathology lies more in the culture than in the child. So I took number 6 and I made up a diagnosis. You won't find it in an ICD or DSM-5 manual, but here it is. The new diagnosis is social gender dysphoria. So we have a present controversy, particularly with children before they reach the age of puberty. Do we need a childhood mental health diagnosis for gender if gender diversity is not a pathology? Why would we have a diagnosis? That's a controversy right now. DSM-5, gender dysphoria of childhood, is an experience of stress or distress and incongruence between designated sex at birth and experienced gender identity. Perhaps it may be possible that we're being diverted from the real issue. What's the real issue? The gender dysphoria diagnosis belongs to the culture, not the child. So here's our new diagnosis, social gender dysphoria, SGD. Definition: stress or distress experienced by a culture or individual within the culture when everything they learned about gender in 2 boxes is incongruent with what children and adults are demonstrating about their gender being infinite rather than binary in nature. So the gender affirmative model's definition of gender health is as follows: a person's opportunity to live in the gender that feels most real and or comfortable, a person's ability to express gender with freedom from restriction, aspersion, or rejection. Now let's bring gender into the consultation room when somebody comes to us. And I'm going to be focusing on children, but this applies to adults as well. The main rubric of the gender affirmative model is as follows when it comes to care. Regarding a child's gender identity, it is not for us to tell, but for the child to say who they are. Is it a boy or a girl? I don't know. It can't talk yet. Now here's the challenge for the clinician. How do you translate what a child is trying to tell us? It's fine to say we can listen, but we can't always tell what they're saying, and they don't always say it in words, and they sometimes say it in very indirect ways. So how do we translate the communications? And I would say that for all of us, it requires being an eye that we watch, an ear that we listen, but also a mirror, that what a child needs is a reflection back to them of themselves. What they typically get from the environment, if not supported, is a funhouse mirror, where what's reflected back to them is an image of themselves that doesn't fit or doesn't exist. So if a parent says to a child, no, honey, you can't be a girl, you're a boy because you were born with a penis, and anybody born with a penis is a boy. And the child says, yeah, but I don't care about my body, I'm a girl. That child is going to experience distorted mirroring if that keeps happening over time. So we are an eye, an ear, and a mirror for the youth that come to us. Therapeutic aims: if a child comes to us and the issue is gender, to discover a child's true gender self, whatever that may be, and it may take a long time to get there. You may be able to do it in an hour. To promote gender health, defined as the opportunity for the child to live fully in their authentic gender with acceptance and without aspersion. Reduce gender minority stress, so we need to deal with the environment that creates that stress. To strengthen a child's gender resilience to meet up with the world, whether supportive or unsupportive, and be able to hold on to themselves. And to support the caring environment so the environment can support the child. So I'll give you an example of that. In Mind the Gap, we have one person Sean Giammattei, who has just set up something called the Transparent Alliance, where parents can come together. It's organized by parents for parents, so they can support each other to support their children. I run a grandparents group through Gender Spectrum, so we can support the grandparents to support the parents who are supporting the grandchildren. So we're looking in all different directions around environmental support. Working with schools is an example of something that's critical because the kids spend most of their daytime, well, before COVID-19, in school. Now, in doing this work, therefore, I discovered that to learn how to translate, we have to understand the food orchard of gender expansive children. And I'll explain how I got there. Many years ago, I was reading the research done by the Dutch on children coming to their gender clinic, where they identified her sisters, kids diagnosed early in life with, at that time, gender identity disorder diagnosis, and had it when they reached adolescence. Those were the per sisters. They were a minority of the kids. The majority of the kids were the D sisters. They had that diagnosis in early childhood, but it was gone by the time they reached adolescence. And the conclusion from that is, until the kids reach adolescence, we can't really know who's who. So we should do the same thing for all the children. It's just listen to them, support them, but don't validate or verify a transgender identity till later. I read this research, and I've been working with expansive kids, and I said, this makes no sense to me. I think they're talking about apples and oranges, and they forgot to differentiate. So over time, I came up with this model of the food orchard of gender expansive children. We have apples, oranges, and later I added fruit salad. So some kids are going to be exploring or affirming their gender identity. Those are the apples. Some will be exploring their gender expressions. Those are the oranges. And some are going to be exploring or affirming both, and those are fruit salads. So to separate the apples, the oranges, and the fruit salad, it's imperative that we separate gender identity from gender expressions, which the Dutch failed to do. Gender identity, who I know myself to be at my core. Gender expressions, if you're a little kid, toys I like to play with, activities I like to do, children I choose to play with, clothes I like to wear, ways I like to move, and so forth. Cheat sheet for gender expressions. How to tell if a toy is for boys or girls. Do you operate the toy with your genitalia? Yes. It is not for children. No, it is for either boys or girls. Somebody updated this for me when I mentioned it's very binary. So here it is in an updated model. Do you operate the toy with your genitalia? Yes. Not for children. No. For a child of any gender. So let's talk about the apples. These are the kids who often show up in the child gender research as the persisters. They're often cross-gender, and identifications early in life continue on the same track into and beyond puberty. They're consistent, persistent, and insistent. Typically, they'll say, I am a, rather than I wish a. So to be or not to be. If a child says, you got it wrong, I am a boy, that's actually a different statement that sometimes I wish I was a boy. And so that's just one tag mark. A lot of the young children who are the apples in early life express body dysphoria. They're angry about what's between their legs. They want to trade it in for something else. And they think somebody did them a disservice by giving them the wrong body. Their gender explorations typically don't present just as their play, but as serious work. So I'll give you an example. Little boy goes into his sister's bedroom, goes in her closet. She has her Elsa costume hanging next to her school uniform. He takes the school uniform and he puts it on, and he comes out in the hallway and says, this is me. I'm a girl. So there's dress up, but it's also communication. Establishing and affirm gender identity is the main order of the day for the apples, and the nature thread of their gender web, often very strong. And this is our youngest cohort of transgender people. Here are some apples. These are children who early in life affirmed a transgender identity. Here's another apple. I take this picture. I like this picture because it comes from the Netherlands, in the place where they were discouraging young children to socially transition. Now, there's an apple myth going around town. To be an apple, just like I said, you have to have been insistent, persistent, consistent in your asserted gender identity since early childhood. Otherwise, you don't qualify. You might even just be following a new teenage fad, rapid onset gender dysphoria. The reality, we have late harvest apples. A person can discover they're an apple at any point in life. They could be 2, 5, 15, 50, in accordance with the consolidation of our gender cells being lifelong, potentially fluid process, rather than fixed at a particular point in time, we can have late harvest apples. The real issue is not rapid onset gender dysphoria, but often rapid onset parent discovery. Parents sometimes don't see it coming and it wasn't there to be seen. And their kids may have known for 8 years. They may have known for 6 months. So it's old to them, but sometimes very new to the parents. Now let's go to our oranges. These are the kids who show up in the research as the D sisters. They're gender expansive, but they don't repudiate their designated sex at birth. They may say, I wish I was a, rather than I am a. So maybe the little girl says, I wish I was a boy so I could play on the boys' baseball team, but I'm not a boy. I just wish I was one. A large number of these children will become gay or queer, not all of them, but a large number, and they're exploring gender on the way to discovering their sexual identities. They do not tend to repudiate their bodies, but they can engage in fantasy play or ruminations about life in another body. So let's take boy number 2. He goes into his sister's closet where there is an Elsa dress and the school uniform. He's not at all interested in the school uniform, but that Elsa dress, yes. He puts on the Elsa dress. He finds 6 pair of socks. He stuffs them in the top, so he has really big boobies, and he comes out into the hallway and says, don't I look fabulous? And that is our child in gender fantasy play. So the explorations are in the realm of gender expressions rather than core gender identities. Nature, nurture, and culture, all strong threads here. And here we have one of our oranges. This is the son of one of my colleagues, identifies as he, wearing his pink butterfly wings, his pink wand, picking out his Tonka truck at Toys R Us. The pictures in the front of each of my 2 books are both, these are children who are oranges. And here's another orange. Now we come to our fruit salads. And I came to the fruit salads because I realized apples and oranges don't cover it all, increasingly so. So this is a tapestry of self, neither male nor female, but one's own creative understanding of gender, both in identities and expressions. Many of these youth resist any gender boxes. They often live in gender middle grounds where there's no either or, but instead all and any. And these are our non-binary, our agender, our pangender, our gender fluid, our genderqueer children and youth. And there's about 20 other different names that I could add to the list, but I'll leave it there for now. Recently, the culture thread of the gender web has shown to be strong. Children are influenced by a new notion of gender infinity. They're learning that gender doesn't come in 2 boxes, and that resonates with them. I would say, among all the children, apples, oranges, and fruit salad, we are witnessing gender revolutionaries. Those children are leading us to learn more about gender than we thought we knew. So here is somebody who would qualify as a fruit salad, who at the time identified as agender, and here is somebody who identified as non-binary. Now, let's go back to the apples, and I'm going to pick up the issue of social transitions. When do we think about a social transition for a child, switching from one gender to another? Here's when. When other possibilities are ruled out, especially gender as a symptom of some other underlying problem. When the central issue is determined to be gender identity, not gender expressions, and we see that it's been stable over time. When it comes from the child, when it's coming from the child wanting to transition, not the parents pushing them to transition, which does happen. When the parents or the caregiving environment can offer positive support for that child transitioning, then you consider a social transition either everywhere or in safe situations, because many people live in environments where it is less than safe for a child to be able to actualize their true gender self everywhere. And we're working on that. So what about the oranges? If the issue is gender expression, not core gender identity, then we carve out space and support for the child to express gender in the way that suits the youth, not the way that suits society. Social gender transition, change in name, pronouns, gender marker, typically not necessary. What about the fruit salads? They're melange. Some may request or benefit from a gender transition, but not necessarily a binary one. Others, they're fine with the sex designated at birth, but they redefine what that means. We need to stretch our thinking to consider the multiplicity of gender identities along with the multiplicity of gender expressions. Now, this is the real concern about the apples. What if they socially transition and change their minds? And it's usually asked like this: what if they change their minds? So I'm going to re-ask it. So what if they change their minds? Then we help them spin together the gender web as they know it now in its next iteration. There are no data indicating that children who change their gender more than once over time, including switching back from transgender to their original gender, are at risk for any psychological disturbances as long as we support them in their journey. Now, from there, I want to go into a laundry list of the clinical challenges in treatment of transgender and gender expansive children. I'm focusing first on the children before they reach the time of puberty. Here they are. Here is the laundry list. How do we establish standards of care, good practices, when we don't have a lot of evidence-based, scientific, longitudinal data? How do we know how the children do who socially transition at 6 when they're 30, for example? Can a young child know their gender? What about the persisters versus the desisters? 3, can a young child know their gender enough to warrant a social transition? 4, if gender variations are healthy phenomena rather than disorders, why a mental health childhood gender diagnosis, especially if no medical care is involved? 5, if gender variations are healthy phenomena, do we need extensive psychiatric evaluations, including batteries of psychological tests, to prepare for treating a transgender, gender expansive child? 6, as mentioned before, the gender affirmative model says if you want to know a child's gender, listen to the child. But how are you supposed to translate what they are saying? Now let's go to adolescents. Laundry list, clinical challenges, treating transgender and gender expansive adolescents. Here's the list. Do we as mental health providers have the confidence to weigh in on gender affirming medical interventions for youth? Puberty blockers, gender affirming hormones, gender affirming surgeries. We are increasingly being asked to do this. Most of us were not trained to weigh in on medical interventions. Number 2, so how do you differentiate authentic gender articulation from gender either as a developmental phase that you're going through or as a solution to another life problem or a symptom of an unrelated psychological disturbance? How do we unpack this? How do we really know what the true gender self is? Number 3, the youth, without a fully developed myelin sheath, which won't happen until they're 25, have the capacity to make informed decisions about irreversible or only partially reversible medical interventions. And those would be gender-affirming hormones and surgeries. Number 4, can a youth receiving gender-affirming medical interventions have the foresight to assent the potential for closure of fertility? These interventions can either foreclose or inhibit fertility. And how is somebody at age 14 be able to know how they're going to feel when they're 30 about different forms of family building to be able to say, yeah, this works for me. I'm fine giving it up. Number 5, what does it mean to deny or limit treatments shown to reduce life-threatening risks if the parents do not consent? In our state, under the age of 18, parents are the legal consenters for puberty blockers, gender-affirming hormones, or gender-affirming surgeries. So what if we do is if a child is at risk if they don't get these interventions and the parents refuse to consent? Or what if we do if medical or government policies don't allow them? We now have in the UK a new ruling, which is definitely being appealed, that no youth under the age of 16 can get gender-affirming hormonal treatment without a court order and approval by the court. So we're asking a judge who knows nothing about gender to decide this child's mental health needs and medical needs. Number 6, if parental acceptance is the key component of good mental health outcomes for transgender and gender expansive teens, which the data, the research is all showing right now, and just starting from Caitlin Ryan's research and from then on consistently, more acceptance, better outcomes. How do we proceed if such acceptance is not in place when we know psychologically the negative consequences, higher levels of depression, higher levels of suicidality, for example, absent such parental support? So I'm going to now just present research findings on 2 of the clinical challenges. Can a young child know their gender? We raise that as one of the challenges. Number 2, are social transitions before puberty in a child's best interest? It's a question. I'm going to present some of the data from our NIH Foresight Trans Youth Care Study, and I'm focusing on our baseline findings on social transitions among the puberty blocker cohort. So just to give you a brief description of PYC, that's the Trans Youth Care Study. It's a longitudinal 5-year study designed to determine the psychological and medical effects of gender-affirming medical interventions, puberty blockers, gender-affirming hormones. There's 4 sites involved: our site at UCSF, Boston Children's Hospital, Lurie Children's Hospital in Chicago, and Children's Hospital, Los Angeles. There's 2 cohorts in the study. There's a puberty blocker group, that's 95 subjects, and there's a gender-affirming hormone group, and that's 316 subjects. All of the subjects are clinic patients. So it's an observational study. It does not in any way influence their clinical care at our gender clinics. They volunteered to be part of the study to be able to offer us research data and how they're doing. So the question posed for the puberty blocker group at baseline, and baseline in our study, a child was either at Tanner stage 2 or 3, typically 2 or 3, a few times Tanner stage 4 of puberty, and was about to begin a course of puberty blockers. We were wondering how many of these kids have already socially transitioned prior to puberty, and what could we learn about their mental health if they did? And we defined social transition as the shift from the gender the child had previously been known to be to the gender the child articulates as being more authentic to them. They can include name change, gender marker change, gender pronoun changes, shift in gender roles, and presentation. So, question, how many subjects had already socially transitioned? We were really surprised. We did not expect this result. The result was a surprising majority. There were 92 of the subjects where we had information on social transition. 3 did not give us that information. Of those, 69 had fully socially transitioned prior to puberty. That was 75% of the sample. 13 had partially transitioned. That was 14% of our sample, bringing it up to 89% of the kids had either socially transitioned or partially transitioned. And partially transitioned meant they did it in certain situations, but not all situations. And then we looked at their social transition history and their current self-identified gender. And you'll see where the stars go. So we had a few kids who identified as trans male or trans female or non-binary, and they had not socially transitioned. They knew who they were, but they did not go through any kind of social transition as they reached puberty. We had 10 of our subjects who were partially socially transitioned, where 5 were trans female and 5 were non-binary and none were trans male. And then we wanted to look at how many years had it been that they had socially transitioned. So we divided between kids who had socially transitioned for 3 years or under by the time they were at baseline in our study. And we found the following, that of those who had transitioned in less than 3 years or less from the time of the study, 26 were trans male, only half that amount were trans female, and 1 was non-binary, coming up to a total of 40. And then we looked at the kids who were socially transitioned for 3 or more years. And this is what we found. It was really just the opposite, that 8 of the kids were identified as trans male, 19 as trans female, 1 is non-binary with a total of 28. So how could we make sense of this? It's different. Here's how I made sense of it. Okay, trans male means you did it later. You went, it was kind of your more years and few of not transitioning, and then you transition later. It is when you are somebody designated female at birth and you are exploring your gender, you have a lot of leeway, given the sexism in our culture, to engage in gender expressions that are typically masculine without a whole lot of trouble being given to you, which often reduces your level of gender dysphoria. So you can just be who you are, and sometimes you don't think about your gender at all. And if you go out in your football uniform, nobody gives you grief. So you can have more years before you feel the necessity of a gender transition or a desire for gender transition. However, if you are somebody who was designated male at birth and discover early in life, this isn't working for me, and you ask your parents, can I wear my dresses to school? And you do, you may get a lot of grief that comes to the gender minority stress, because it's not acceptable for a little boy to be wearing a dress to preschool. And people say, you can't wear a dress, you're a boy. So there may be, in terms of the environmental provisions, a higher loading of gender dysphoria at an earlier age for trans female children. and a desire to transition so they can have gender health and fully live in their gender selves without getting grief every day for doing it. So that is one explanation that why we have these significant differences here between the under 3 years and the over 3 years. So I was also interested in asking the question, is there any difference just between how long you lived in your authentic gender and mental health outcomes? So first, the numbers tell us, before we go there, around social transitions, that almost 90% of the youth joining our study to start puberty blockers have already socially transitioned, either fully or partially. Second, the social transition occurred anywhere from the year before entering the study to 6 or more years before entering the study. So are the kids doing all right? Well, this is what we found. Here was our general hypothesis. We were comparing youth who socially transitioned less than 3 years versus 3 or more years prior to initiating puberty blockers. Our hypothesis: those with more years experience will show more positive psychological functioning at baseline compared to youth with fewer years of experience. We chose 3 years because we felt that giving children that age, that's a long span, 3 or more years in terms of dividing up childhood into segments. Here's what we found. We only included the subjects who had fully transitioned for this part of the data analysis. Children with 3 or more years of social transition were rated by their parents as having significantly higher scores on overall quality of life and quality of life subscales, self-efficacy, positive affect, and general life satisfaction than children with less than 3 years of social transition experience. Children with 3 or more years of social transition rated themselves, because we had both parents and children doing ratings, significantly higher on the cumulative quality of life scale than children with less than 3 years. It didn't reach significance, but it trended in the same direction as the parents' ratings on the subscales of self-efficacy, positive affect, and general life satisfaction. So the benefits of having more years of social transition before puberty: your parents will see you as being better able to take care of things on your own, have more positive feelings, and be more generally satisfied with life than if you had socially transitioned less than 3 years ago. If you're the child, you will agree with your parents. So the conclusion about one of our clinical challenges: young children seem to be capable of delineating their authentic gender, and those who socially transition are showing positive effects, both in their own and their parents' estimation. And here they are. Thank you. So I'm now going to open it up and send it back to Casey for questions, discussions, clarifications.
Thank you so much, Diane. If anyone has any questions, please submit it into the chat and we can start our Q&A. I have one question of knowing how important parental and societal support is for allowing a youth to explore their gender. What's something that might be helpful for the kid who comes kind of in distress to a, maybe a primary care provider or, psychiatric intake, who says, this might be going on, I'm exploring my gender, but don't tell my parents or don't let anyone know because I don't know how it'll go. And I know that can probably be a whole talk, but.
But it's a critical question, and it's under the umbrella of what we like to take a family systems model, because there is no, when they say there's no infant without a mother, there's no gender expansive child without a family. and the family is an important component. But going back to the first thing is to listen to the child. That's where you start. That what this youth needs is a room of their own. They need a room of their own with confidentiality, with somebody who's a gender specialist, who will abide, in my book, will abide by the gender affirmative model and will create a safe environment to explore gender further with the understanding of working towards being able to communicate to the people around them who they are, or assessing whether it would be too dangerous to do so, because that does happen sometimes. And in that case, when I was saying the therapeutic aims, that is building gender resilience. That is making sure there's an alternative support network for the child where it is not safe, or they don't have parents to tell, so that they know that there is a community surrounding them who will support them and build their gender resilience, and know that when they're feeling stress, distress, anxiety, depression, often it's because the people out there need help with gender literacy and understanding who they are. And in the meantime, you will address the anxiety, the depression, which shows up so often, by having them know there is somebody who will mirror them, who will support them. And one of the things, because this happens so often, Casey, I'm glad that you mentioned it, because it starts with the primary care person who then finds a therapist. And it's often tricky because the parents want to know, why do you want to go to therapy? And the kid doesn't want to say why they want to go to therapy. But the important thing is they do get to therapy. And they need to know that there is confidentiality, but that also there's something that I call and we all call the parental acceptance spectrum. That where your parents are now, if you're assessing them as not being supportive, doesn't mean they'll end up there. And that there may be a facilitated way, and if you're the mental health provider, that you can help with over time to be able to communicate that. And there is what I'm also just observing is the other side of it, which is word on the street among trans youth is that don't count on your parents, they'll never understand you. There becomes a belief system that your parents will not be receptive and accepting. And if they're confused or have doubts or like off balance, that's proof. And I think we need to dispel those myths around. There's a lot of parents who are there to receive what their kids are telling them. And when they feel blown over by it, like when there's sudden onset parental discovery, they need a room of their own. There needs to be a room of their own so they do not communicate to their child, but with themselves and within themselves, perhaps with somebody facilitating what their experience is, what their own gender journey is, understanding that there's a starting place, but that's not the ending place, and understanding how important it is around gender minority stress to be able to create a firewall so that some of those feelings and questions are insulated, not directed after you. And then there's the last thing I would mention about youth. Often this is with younger kids, that there are situations where there's like, say, gender by season and gender by location. So here'd be an example. We're going to grandma's for Thanksgiving. You can't wear your dress there. Grandma voted for Trump and you can't wear your dress there. So that can create a lot of stress and people decide how to handle this differently. So one solution is think of yourself as wearing a Harry Potter cloak. Now, I made up this metaphor well before we found out that the person who wrote those books is not our friend. Okay. So I'm still going to hold on to the Harry Potter cloak as a way that you are in control. You're putting on your cloak and making part of yourself invisible, but that's a strong, wonderful part of yourself. And that's just because of the environment out there, and we're working on it. And, again, when I keep using the example of when a boy wears a dress, you get flat. We want to tear that down. We want to get to what the children are teaching us. Don't you know they're just people clothes? Anybody can wear a dress. It's not a boy's thing or a girl's thing. Colors aren't gender, they're just things. And so that is part of the social component, which means mental health professionals are often trained to stay in their offices and deal with internal issues in the psychological. Around gender care, we can't do that. We have to step outside our offices. We have to promote gender literacy in the culture. If we choose to, we become advocates. We may be expert witnesses in courts, but this is the social phenomenon, not just a psychiatric or psychological phenomenon. And I think we have to embrace it. So I'll stop there.
Thank you. And maybe you can share that resource for how to connect people or parents to that Transparent Alliance or Parents Alliance.
I believe, and everybody here who gets, I believe it's transparentalliance.com. I'm doing this from memory, but I'm pretty sure it's transparentalliance.com.
There's a few questions about the study, and it's looking at cultural determinants or social determinants. And was that involved in the study when looking at different cultural backgrounds?
I will say yes, and not enough. We have data, and just like any study, when you're done putting the protocols together, well, why didn't we ask this and why didn't we ask that? So yes, we have some data on that, which I didn't present today, but I wish we had more on intersectionality in terms of race, ethnicity, cultural differences, national differences. I would say we have some.
A few questions about kind of parental responses and how to, and maybe how, as a provider, we can help parents kind of come along with their child's gender journey. One of which is, if the parents respond with they're against social transition because they themselves already relate to these feelings of gender expansive exploration when they were younger, and they say, oh, I grew out of it, so will my child. Do you have anything that you might say to them that would help?
Actually, I think one thing that's really helpful is to ask them to say more about themselves, and ask them to really do the gender exercise of like, well, tell me about your gender. Tell me, where you started and where you came to. And I would like to understand it more. And then maybe we need to differentiate it from what your child's experience is. So now we'll hold yours, but maybe let's give me some more information about them. And so we can hold them both. What I have that has come recently, so self-disclosure, I'm a feminist in the 1960s, and I hold to those feminist principles. So I have had lots of parents and grandparents who are my peers say, this makes no sense to me. And why are all these girls wanting to become boys? You can be a strong woman. You can express your gender any way you want. I did. And why this feels like it's falling into heteronormative, male-dominated trap. And this is particularly around trans boys. And it's a great belief system, but it does not mirror these children's experiences at all. And so I think what we have to do is put down our own looking glass and really say, okay, that's the lens that you're seeing it from. Now let's see if we can also identify the lens that your child or grandchild is seeing out from. And what are they seeing inside? And let's put those two together. And, and here'd be another example of that. I'll have parents say, I'm not going to endorse any medical interventions. I think it's a trap of capitalism to enforce body changes when people should just accept the body you have, which is, or maybe 100 years from now, that will be true. But in 2021, often what really helps is to ask the parent who doesn't have breasts and identifies as male. I want you to imagine if you woke up tomorrow with breasts and they just were waiting this many years to develop, would you simply accept them and say, this is my body, so I will live with it? That's often a wake-up call around their children's sense of wanting to consolidate and having congruence between bodies and who we know we are. And this may be universal, it may never change, that we are combination of our bodies, our psyches, and our social experiences. And so bodies may always send messages about this isn't, I want to change it for the purpose of my gender. I hope that answered that in terms of just parents.
And I imagine a lot of that can be used for parents who come in and say, oh, I just found out. I also read this thing about rapid onset gender dysphoria, or as you like put it, rapid onset parent discovery. And if there any more that you could say about people who come in specifically with that acronym, and how to coach through that?
First of all, it's happening every week, probably every day in a lot of our practices. And it is in the media everywhere right now. And parents come in with that information, and which has different meaning for each parent. So first you have to find out what the meaning is for them. And listen, and just, okay, so you read that, what did that mean to you? And often is, well, I think that's my kid. My kid never showed any signs before, and all of a sudden they're under the influence of the LGBTQI group at school. And of course, later we have to ask, why did they join that group? Teens like to find people like themselves. But he's there and hear what they have to say. And I think in terms of from a gender affirmative perspective, say, I'll take that into account. Let's also listen to what's going on with your child, present some things from the gender affirmative model as well, and basically say, look, the work is the same for us as it's going to be for you, is to get in focus your child's authentic gender, whatever it is. And if they've been influenced by other people and that's not their core gender identity, let's find out. But if it is, let's make sure we provide gender health. And let's not tell any youth, you can't think that, you can't feel that, in terms of even if it is exploration. But that's what adolescents are supposed to do. That's the diagnosis of adolescence in our culture, is exploring identity, self, how everything fits together. So I do think it is important, and I do this all the time, is saying, I know you may have read that research. That research is incredibly flawed. And here's why. It's not scientific. It's ideological. It's biased. And the popular account of it by in Irreversible Damage by Abigail Schreier is written by a person who knows nothing about gender expansive children, nor is a mental health professional, nor a medical provider. And so I would like you to take that into account. But it's a dialogue and it's a working relationship, because parents both have expertise about their children and they have blind spots about their children. Every parent. I don't think I've ever met a parent who doesn't have both. And gender can create big blind spots. And so I think it's kind of like, if we think of a metaphor, if we were ophthalmologists, that we want to reduce the film over the eyes so you can see clearly.
Well, thank you so much, Dr. Ehrensaft. It was an amazing talk. The praise is coming through the chat as we speak. I will point out to there are a few links in the chat for people if they want to get involved with the Mind the Gap group, as well as the Trans Family Alliance link is also in there as well.
Oh, it is, okay, because people can also email me. I don't know if that was one of the links. If you want to know more about Mind the Gap, it's diane.ehrensaft@ucsf.edu. I'll put it right here. And so anybody who's interested, either that or any questions you have after today, or family you're working with or youth you're working with, I'm putting in my email right now.
Thank you so much.
And thank you everybody for being here. And hopefully, like Johnny Appleseed, we're just going to spread these ideas further.